Hi, good day, everyone. I'm going to talk to you about the role of FODMAPs in functional digestive disorders and focus on the data that we have for the use of low FODMAPs diet to treat children with functional GI disorders. These are my disclosures. Okay, so what is the low FODMAPs diet? The low FODMAP diet is low in poorly absorbed and fermentable carbohydrates and uses dietary restriction and rechallenge to determine each individual's tolerance to various short-chain carbohydrates. Due to its growing popularity, a simple online search for a low FODMAPs diet can give almost 400,000 results. But what exactly are FODMAPs? So we know it's an acronym with the O standing for oligosaccharides, which includes fructans and galacto-oligosaccharide. They're found naturally in foods like wheat, rye, nuts, legumes, onions, garlic. There's no human enzyme that's capable of breaking this down, so they're malabsorbed in everyone. The disaccharide in FODMAP is lactose, and we know that requires lactase for its absorption. Lactase activity can be reduced in certain populations like Asian and Mediterraneans, also with increasing age, and also due to intestinal inflammation. But many individuals have adequate lactase production to digest their daily lactose intake, and so usually you don't need to restrict lactose in a low FODMAP diet. The monosaccharide in the FODMAPs is fructose. It's found in some fruits like apples, pears, watermelon, mango. You can find it in honey, some vegetables. It's also used as a commercial sweetener as fructose or high fructose corn syrup. It's the smallest of the FODMAP. It has the highest osmotic effect with the ability to draw water into the bowel lumen. And it's poorly absorbed across the length of the small bowel. And this slow progressive absorption creates an osmotic effect. The polyols, identified most commonly in foods as mannitol and sorbitol, it's found in apples, pears, cauliflower, mushrooms. In addition, there's xylitol, which is an artificial sweetener in sugar-free gum. They also are slowly absorbed along the length of the bowel, like fructose, and so exert an osmotic effect and so should be considered in patients as a contributor to IBS symptoms. Okay, so how did it all start? Well, starting with researchers in Australia at Monash University, they first focused on fructose and fructans as the main culprit for GI symptoms after ingestion of food. As their research progressed, it became apparent that polyols and galacto-oligosaccharides were also part of the puzzle. By the mid-2000s, the developers of the FODMAPs were the first to recognize that short-chain carbs, known as fermentable oligo, di, monosaccharides, and polyols, FODMAPs, are resistant to digestion. Instead of being absorbed into the bloodstream, they reach the far end of the intestine where the gut bacteria resides, exerting their effect. Since the launch of the Monash University smartphone app in 2012, there's been increasing popularity of the low FODMAP diet, driven primarily by the poorly treated IBS in the past. Patients search for a cure, especially natural cures, and the proven response for IBS patients to a low FODMAP diet in the literature. There's been diversification of the low FODMAP diet. Instead of just high and low FODMAP foods, we have moderate categories. Instead of yes or no to certain foods, we need to distinguish between different varieties of berries, mushrooms, etc., before deciding on their suitability as part of a low FODMAP diet. So why do FODMAPs cause a problem? Several factors play a role in determining whether a FODMAP carbohydrate is going to exacerbate a symptom in a specific patient. One, of course, the amount ingested, the small enzyme activity of that patient, the colonic microbiome of the patient at the time of the carbohydrate ingestion, and then a host of other factors that can include the presence or absence of low-grade gut inflammation and, of course, visceral hypersensitivity. The premise underlying the benefit of the low FODMAP diet in IBS is simple. You have malabsorption of short-chained carbohydrates that leads to distal and ileum colonic fermentation. This generates gas and osmotic load, again causing further luminal distension. For most people, this won't cause symptoms or just minor symptoms that would self-resolve. But for IBS patients, if you overwhelm their visceral hypersensitivity threshold, they can get symptoms including pain, bloating, flatulence, through stimulation of mechanoreceptors, as well as various chemoreceptors. So who's consuming all these FODMAPs? Well, mostly everyone. FODMAPs are known it's well known that they're common in the Western diet, but little is known about the presence of FODMAPs in other diets. Various other diets around the world contain many high FODMAPs foods. There are no good studies comparing the consumption of FODMAPs by region to the higher prevalence of functional gastrointestinal disorders in these regions. And as shown in the data on the map, the epidemiology of pediatric abdominal pain disorders is scarce in some areas. Overall, the consensus view suggests that the westernization of diets is linked to the development of functional gastrointestinal disorders. Notably, though, Asian populations are shown to consume high amounts of FODMAPs with legumes, milk, wheat, garlic, cauliflower, cabbage, etc. But they have a reportedly low incidence and prevalence of functional gastrointestinal disorders. Further studies are necessary to show if there's a link between the consumption of FODMAPs in the diet and the development of functional GI disorders in children. We are actually currently conducting a study in Miami at on the intake of FODMAPs of children in the Miami area to determine if the high consumption of FODMAPs in our area may be related to increasing prevalence of functional gastrointestinal disorders in our population. Okay, so FODMAPs and pediatric functional abdominal pain disorders. In children, there are few trials evaluating low FODMAPs in functional abdominal pain disorders. This narrative, composed by experts in the field, pooled the current knowledge as of 2019 on the role of FODMAPs in the diet in reducing symptoms associated with pediatric FAPDs. As of 2019 in children, there was only one randomized control trial and one open label study that reported positive results of a low FODMAP diet. One randomized control trial also showed exacerbation of symptoms with fructans, specifically in children with IBS. The review found no benefit of a lactose-free diet in these patients. However, fructose-restricted diets were effective in 5 of 6 of the studies that were conducted. This confirms an Italian systematic review in 2018 that found similar results, concluding that there's promising data, but further data was needed to better clarify the role of FODMAPs and fructose-restricted diets in IBS in children. They also found no evidence to support the use of a lactose-restricted diet in children with functional gastrointestinal disorders. So what about FODMAPs and IBS? This is probably where we have most of our data for the benefit of a low FODMAP diet. Regarding the evaluation of a low FODMAP diet in children with IBS, the first pediatric study was published in 2014, and there has since been growing evidence to support the use of a low FODMAP diet in pediatric IBS. In a double-blind crossover trial of children with Rome-3 criteria diagnosis of IBS, children were randomized to receive a low FODMAP diet or the typical childhood American diet. GI symptoms were assessed. There was less abdominal pain in the low FODMAP compared to the typical American diet. And compared to baseline, children had fewer daily abdominal pain episodes while they were on the low FODMAP diets compared to the episodes on the traditional American diet. That led the authors to conclude that in childhood IBS, a low FODMAP diet decreases abdominal pain frequency. More recently, a study of 60 children 6 to 18 years old who were diagnosed with IBS using Rome-4 criteria. Patients were randomly selected and divided into 2 groups. 30 got low FODMAP diet, 30 got a general protective standard diet. And the authors found that a low FODMAP diet seemed to be more effective for symptom control in IBS. Finally, there was a retrospective study to examine the use of low FODMAP diets in children with IBS, and 79% of the participants reported an improvement of symptoms on a low FODMAP diet, with fructans identified as the most common symptom-causing carbohydrate. The authors again concluded that a low FODMAP diet is a useful dietary treatment strategy for children with IBS. What about FODMAPs and constipation? So that might seem counterintuitive to use a low FODMAP diet to treat constipation. However, alterations to the gut microbiome, intestinal motility caused by gas production, the resultant pain and bloating may play a role to justify the use of FODMAPs in constipation. There was a pediatric study done in 2019 and found that there was some improvement in constipation in a retrospective symptom survey of patients, with 11 on 13 reporting some improvement in their constipation. In an adult European study done by Pedersen et al., they performed a randomized, unblinded controlled trial comparing FODMAP diet, lactobacillus diet, and a normal Danish diet, but they found there was not significant improvement for the IBS-C subtype with a low FODMAP diet. However, IBS-D showed significant improvement. All in all, there was poor evidence and more rigorous trials are needed to establish the efficacy and safety of a low FODMAP diet in constipated children. Low FODMAPs and functional dyspepsia. So we know the mechanisms of functional dyspepsia are altered motility, visceral hypersensitivity, low-grade mucosal inflammation, dysbiosis of the gut, and certain dietary constituents may provoke symptoms of functional dyspepsia. And a low FODMAP diet may impact functional dyspepsia by causing changes in the microbiome, duodenal homeostasis, and inflammation. However, there's currently no high quality evidence to suggest that a low FODMAP diet would be of benefit in functional dyspepsia in adults or children. One English study comparing low FODMAP diet with standard dietary advice for reducing epigastric discomfort in adults with functional dyspepsia showed promise for a low FODMAP diet in relieving epigastric symptoms. However, most of the patients that were studied were overlapping functional dyspepsia with IBS, 81% of them. So that makes the results unreliable for functional dyspepsia alone. An Australian study in 2020 found no significant improvement in a small group of patients, adults, on a low FODMAP diet with functional dyspepsia. Further, an adult study using the low FODMAP diet for PPI refractory GERD found that FODMAP's diet had a similar effect as usual dietary advice for GERD. And to further cloud things, the role of the low FODMAP diet in functional dyspepsia, a cross-sectional study of almost 3,000 adults in Iran actually found that a low FODMAP diet increased the risk of chronic dyspepsia, making it 2.5 times more common in women who consumed a low FODMAP diet. So we need to decide if we're going to use a low FODMAP diet in our patients. Can we test for FODMAP intolerance to make this decision? Breath testing has been used for carbohydrate malabsorption in many patients for many other conditions. And it's sometimes used for patients with functional abdominal pain disorders with a primary focus on fructose. So breath testing is simple, non-invasive, which makes it a good choice for pediatric patients. However, there's conflicting evidence on the relationship between intolerance, which is the induction of symptoms, and malabsorption, which is the actual measured hydrogen or methane response to the ingested carbohydrates. So in order for us to utilize breath tests to make a decision on a low FODMAP diet, we need a test that we find reliable and accurate. A review of the evidence shows there's poor intra-individual reproducibility in breath tests with repeated testing for fructose, and repeatability for malabsorption status was also inadequate. Additionally, symptom induction during breath tests poorly correlated with the presence of carbohydrate malabsorption. An Australian study found that 21% of patients with fructose malabsorption, but 25% of patients without fructose malabsorption experience symptoms. So further, fructose breath tests in a study over 500 patients to identify fructose as a specific trigger for IBS also found poor reproducibility and the lack of malabsorption with symptom induction in the IBS cohort compared to healthy controls. Further, in IBS, patients with small intestinal bacterial overgrowth, sugar breath test may be falsely abnormal. And when small intestinal bacterial overgrowth was treated, the breath test actually normalized in the majority of patients, making these tests less reliable. Altogether, the evidence suggests that breath tests have limited value because they're not reproducible, and symptoms can occur in patients with and without malabsorption symptoms, so without malabsorption, and that you need to rule out small intestinal bacterial overgrowth for our patients before making clinical decisions around FODMAP's diet in functional GI disorders in children. However, there was this North American consensus that was put out in 2017, and they had a slightly different opinion on the use of breath testing. In fact, they actually came up with some recommendations. One, they suggested that you can use breath testing for the diagnosis of carbohydrate maldigestion syndromes. They found that 25 grams of fructose could be used to test for fructose malabsorption. They suggested, similar to the other studies, that bacterial overgrowth be ruled out prior to doing a fructose breath test. They consider that a rise in greater than 20 parts per million from baseline in hydrogen during the test should be considered positive for fructose breath testing, despite the results of prior studies that showed that there was a discordance between symptom induction and malabsorption measured by hydrogen production. So alternatively, an Italian group of experts actually disagreed with these recommendations due primarily to the lack of significant published validation studies for breath testing in GI disorders for FODMAPs, and they disagreed on the dosing of fructose. They also further thought that the fructose breath test had no positive predictive value for a fructose-free diet effect. And in conclusion, a fructose-restricted diet could be suggested in clinical practice after symptom induction, possibly without the need to perform a breath test, just based on the symptoms occurring post-ingestion of an offending food. So we decided now if we want to introduce this FODMAP diet, how are we going to do it? So our initial goal is to avoid all foods with high FODMAP content in normal serving sizes and replace them with low FODMAP foods. This swap or exchange is important as FODMAPs are found in multiple food groups and ensures that the patient meets their nutritional needs. The low FODMAP diet is typically taught by a qualified dietitian during a clinic visit. This diet is done for 2 to 6 weeks, after which there's a reintroduction phase that's closely monitored until a balance between tolerated doses and symptom control is achieved. For patients that immediately have treatment failure during a 2 to 6 week period, you want to consider, do they have poor compliance? Are they inadvertently taking in FODMAP containing foods? Is it an alternative food intolerance and the symptoms are not related to FODMAPs? Do they have non-diet related mechanisms for their pain, bloating, and distension? A lack of response to FODMAP diet should be followed by a high FODMAP food challenge to confirm that these symptoms are not due to FODMAPs, in which case, of course, the diet is discontinued. What's the complications that can occur on a low FODMAP diet? So while a low FODMAP diet can reduce the symptoms of IBS, it can also cause a reduction of potential prebiotic and fermentative effects that might adversely affect the colonic microbacteria. The long-term complications of reduction of FODMAPs is unknown, but there was a single-blinded randomized crossover trial of 27 IBS and 6 healthy patients. They received 2 diets differing only in their FODMAP contents, and then they crossed over. They collected stool on the habitual diet and on the interventional diet, and fecal indices were measured. They found that the low FODMAP diet was associated with a higher fecal pH, greater microbial diversity, but a reduced total bacterial abundance when compared with the standard diet. In another study, a mean daily intake of approximately 5 grams of oligosaccharides seemed to restore the microbiome. This supports the promotion of the full FODMAP diet program, which includes restriction followed by a reintroduction phase. Low FODMAP diets may also result in fewer daily caloric intake. During a 4-week diet, patients following a low FODMAP diet had a statistically significant decrease from baseline in several micronutrients. Low FODMAP diets can be deficient in thiamine, iron, calcium, folate, vitamin D, natural antioxidants, especially in subjects with limited access to the expensive alternatives for this diet. They can also reduce the intake of fiber. Despite this, overall adult studies have concluded that a low FODMAP diet does not jeopardize nutritional intake when supervised by an experienced dietitian. There was a prospective study by a dietitian-led low FODMAP diet for 18 months and found that the low FODMAP diet was adequate in macronutrients, micronutrients, and energy intake. Yet still, there's safety concerns around the diet that includes elimination and restriction that can compromise the nutritional and psychological health, especially a concern for young children who may be at risk for eating disorders, picky eating, etc. We recommend a careful patient assessment and management through a FODMAP-trained dietitian, which will reduce the risk of such negative outcomes. So while the effect of the low FODMAP diet has been extensively studied in adults, especially in adults, the second phase of the diet, which is the reintroduction phase, is less studied both in children and adult populations. In one study published as an abstract looking at the second phase of the low FODMAP diet, there was a gradual reintroduction of FODMAP-containing foods during a 6 to 18-month period in 100 patients. The authors concluded that 71% of patients continued to have satisfactory relief at 1 year following the reintroduction phase. And generally, there's no standard protocol for reintroduction techniques of higher FODMAP containing foods. One approach would be to start with fructans and galacto-oligosaccharides because they have proven prebiotic activity, and this early reintroduction can reduce the possible negative effects of the diet. Another approach would be individualized to the patient's needs. So based on patient's symptoms, their food's likes and dislikes, etc. Or finally, a dietitian may start with the least bothersome FODMAPs, such as the polyol-containing foods, then go to lactose and fructose, and then the more troubling foods like fructans and galacto-oligosaccharides. Regardless of the approach, you do one food item every few days until an achievable dose is found where symptoms are manageable and controlled, and the diet is nutritionally accurate and not overly restricted, especially important in young children. The long-term goal of FODMAP diet education is to reintroduce high FODMAP foods to personal tolerance, and that's a term coined FODMAP personalization. What about how do parents and children feel about this diet? So few studies have assessed parental or child satisfaction with the low FODMAP diet, which can greatly affect compliance and outcomes in children who are prescribed this diet. There was a retrospective study done in New Zealand that looked at the efficacy of the low FODMAP diet in children 4 to 17. They found that 85% of the parents and children found the diet easy to understand, but only 17% would be interested in any further restrictions or alterations to their diet. Notably, all children and their families received 3 dietitian consultations whose support could explain why they might have found the diet so easy. Another study looking at FODMAPs as compared to the NICE diet in children with IBS looked at parental satisfaction, and a significantly lower percentage of parents found it easy to follow the low FODMAP diet compared to the NICE diet. On the market, there's also a lack of food products clearly labeled low FODMAP or no easy labeling or identifiers for patients to figure out what's low FODMAP compared to like the gluten-free or dairy-free markets. So that can make both following a low FODMAP diet and reincorporating FODMAPs into the diet very challenging. Medications. So can we do anything else besides use this a FODMAP diet, a low FODMAP diet? So enzymatic supplementation has also been used for other malabsorbed carbohydrates. In adults with fructose, the addition of xylose isomerase during a fructose challenge decreased breath hydrogen production and symptoms. In adults with IBS who was sensitive to galactans, they co-ingested alpha galactosidase and they improved their GI symptoms. A randomized double-blind placebo-controlled crossover trial showed assessed whether oral alpha galactosidase with foods high in galacto-oligosaccharides and low in other FODMAPs would reduce symptoms. And they found that there was a clinically significant reduction in symptoms with this enzyme. So this can be used as an adjunct to therapy. Similar enzymatic supplementation trials using these or other enzymes in children with functional bowel disorders would be necessary in children. What's next in the world of FODMAP? So FODMAP research continues. Several randomized controlled trials, systematic reviews, etc. are underway. And FODMAPs have even expanded beyond the world of functional gastrointestinal disorders to explore the role of this diet in other pediatric conditions such as IBD and bacterial overgrowth. So there's some resources that you can provide your patients if you do decide that you want to go on a low FODMAP diet. These resources are developed in an attempt to circumvent inaccuracies that you might find on the internet via Google search. They are based entirely upon measured food content and regularly updated. They can be used clinically to aid our patients when prescribed or for various research projects to gain further insight into the world of the low FODMAP diet and pediatric GI disorders. They include the Monash University Low FODMAP Diet Guide and the Monash University Low FODMAP Diet app. Thank you very much for your kind attention. And I hope that everybody found that helpful. Thank you.